Hello and welcome to SOMC's Research Symposium for 2021. I'm going to go ahead and share my screen. My name is Roger Danini, and I did a research study on vascular access knowledge gaps. Just want to thank Mary Kate Diltz and Valerie D. Camp for their mentoring on this project. Without it, it would have been impossible. So thank both of them very much for all the knowledge they poured into this. So I am a vascular access board certified nurse. So certainly one of my passions is vascular access, and being up to date on that vascular access is important to me. I've attended several national meetings on vascular access and just have brought back all kinds of information that has helped me to become up to date on vascular access. So I think every research project that a person has kind of starts with a story. And in this case, I think the story goes back to something called MASH. MASH stood for My Awareness Stops Healthcare Acquired Infections. This was a project that was put on by April Sanders, Autumn Brooks, Kathy Davis, myself, and I think there were at least 3 or 4 other presenters that came in that day and gave content on how to decrease hospital-acquired infections. So shout out to April. She led this project and just great leadership on the project, and you could tell it truly was her passion to protect patients. And just wanted to say thank you to April for starting that project and for allowing me to do the research that was in conjunction with that project. So thank you very much, April. Purpose truly in this case was to present to nurses and to be able to get across what impact our care has on each and every person. And truly, when we were doing this, it was eye-opening. You know, some of the nurses even were to tears on some of the stories that were presented, specifically the Granny story by Dr. Byers. Very impactful, probably some of the most impactful education I've had in years. So great project and major impact on nurses, I believe. So at the end of the MASH education, we kind of broke out into groups, and these groups were designed to gain information. There's such a thing as an Ishikawa diagram, also called a fishbone diagram in many years past. And these Ishikawa diagrams were used to kind of track the things that the nurse groups thought were the most important in improving care and decreasing healthcare acquired infections. So many pages of these, if I remember, somewhere between 6 and 13 pages worth of information were obtained. So it was a lot. And one clear need out of all that information was that the nurses felt that they needed hands-on education. The distance learning, it was okay. Computer learning was okay, but they missed having that hands-on education where they could talk to an expert and they could ask questions and give situations and get feedback on those questions and situations to be able to do their best. So that was a key theme we saw in all of the Ishikawa diagrams, is they wanted hands-on access to an expert. So previous to this, I had probably two months previous, I had been taking training for PICC insertion in Dayton, and I met Mary Smith. Mary Smith is a owner of an education company that teaches PICC placement, and she does research herself. And one of the things that she presented during our training was what was called a knowledge gap survey. And that knowledge gap survey was of a hospital out west, and just showed what their needs were and how vascular access could be improved in their hospital. It was a simple survey. It wasn't anything crazy, but it did show me how a knowledge gap survey worked, and how you can use that knowledge gap survey to improve vascular access. So along with the meetings after this MASH presentation, we had talked about this knowledge gap survey that I had seen from Mary, and we had presented it to our director as well, which was Mary Kate. And Mary Kate said, well, why don't you do a research project on this? And from that point, that's where it kind of started forming into knowledge gap survey and research survey. So I just wanted to show you a little bit of the cards that were turned in for the MASH education, the HAI education, healthcare acquired infection education. So just showing you the feedback from those nurses, and of course there's some color coding there with that you'll see in a minute, but it just shows what their actual questions were and what they thought could help. So this is an example of the Ishikawa or fishbone diagram. And one thing that this shows you is it shows you, what they thought the main issues were. And then from that point, the group that was doing the Ishikawa, we were broken up into many groups throughout the room, but that group then voted on what they thought was the most important thing. And the red dots are what are used to do the voting. So. All right, so out of all those diagrams, three key areas were identified. Number one was the education. So that's where the research project form and the questionnaire or survey was made by myself and Kathy Davis. We just tailored that to what's used inside of SOMC. Certainly things like ports and PICCs and midlines and art lines. So those type of questions were integrated into the questionnaire to get a feedback of what the nurse's knowledge base was of these products. So, and we had talked about many different things, but one thing that kept coming up was super users, to have super users on each floor that were the vascular access gurus for each floor, or the HAI gurus for each floor. And we definitely explored that. We talked about central line dressings and dressing changes and flushes. And we also talked about education and using the educator group to disseminate this information. We also talked about checkoffs where nurses could come in and they could check off on central line dressings or port dressings. And we talked about the ambulatory infusion clinic and the ICU doing these hands-on checkoffs. Another thing that was a theme was resources. Did everybody have the resources that they needed to be able to do this project? Could they get a hold of every product needed? Did they have the right dressing? Did they have the right flushes? Did they have the right securement devices? So looked at that and being able to provide those resources to each and every floor and making sure that there was an appropriate amount of stock for each and every floor. So continued. One theme that we saw, or one thing that was brought to our attention, was that our central line dressing kits and our port dressing kits really had a flaw. And that flaw was that they didn't have a sterile saline inside of them. So from the get-go, the dressing change was not done sterilely. If you pull a sterile saline out of your Pyxis, the inside contents of that sterile saline are sterile, but the outside of it is not. And that's what it actually says on the plastic wrap around it, that the outside is not sterile. So you contaminate your field just by putting a flush on that field. So one change that was made then was to go back to our kit manufacturer and say, hey, we need a sterile saline placed in each one of these so that we are able to do this as a full sterile process. And I really think that has had an impact, and I certainly know it has improved care for our patients. So third thing as a feedback theme is accountability. So one thing that the nurses brought up time and time again was there needed to be accountability. If you were doing everything right on your sterile procedure, but another person was doing multiple things wrong, and then there was no accountability for doing them wrong, then it just left it open to people doing whatever they wanted. So their thoughts on not only central lines and PICCs and IVs, but also like Foley's, was make sure that there was accountability, that people had to do this correctly, or there would be repercussions to not doing that correctly. And another thing that came out of the meetings on this, and even the called eclampsia team, was we talked about super users on each floor. Well, why not have a specific team that had the skill set to deal with the central lines, and to be able to have those people handle all central line dressing changes, so that it came down to a condensed group. And this actually follows research done at Penn State on limiting the group size of those people who deal with central lines throughout a hospital. So that kind of linked together with some previous knowledge, and it ended up forming our team that we see today, that is the rapid response line team, as well as the AIC nurses that go around the floors and change the dressings and look at the dressings and make for sure if a line doesn't need to be there, that line is pulled. So it really has kind of, the research kind of flowed into what we actually use now as a line team. Task lists were formed off of the information that was gained, and I just wanted to give you an idea of what those task lists looked like. So there's just a little glimpse. So design-wise on the research, certainly we put together all the questions, but how did we present these questions, and how do we get that out to people and give them enough time to be able to answer it, because we're all busy and putting it out for a day or two is probably not enough. So I designed a study there that would be 2-week periods, And those 2-week periods, there would be a total of 3 of them, about 6 months apart. On the first one, it would just be a gauge of what is the knowledge in SOMC, what vascular access knowledge do we have, what are the results of the questions that we put out. So that first set was just our baseline. After that, myself, some of the leaders of ICU, Kathy Davis, April Sanders, multiple leaders went and rounded the floors and talked about all the different identified issues from our initial survey. So that the content was there. It also coincided with us launching the line team. So it was a twofold project. So we addressed the knowledge gaps, and we discussed what the line team would be doing on everyone's floor and what the process was, and how to get a hold of the line team. So initial survey, hands-on education prior to the second survey, and then again, hands-on education prior to the third survey. And of course, the setting was SOMC, a 220-bed acute care hospital. Implementation, a 3-phase survey, and each survey was 6 months apart and lasted exactly the same amount of time, which was 2 weeks. We did have the article in the paper before each survey, about a week, I believe, week to 10 days before the survey came out. Then we ran an article that said, you have the opportunity to participate in a research survey and impact vascular access within SOMC. Please take this survey, and it even gave the time range of how long that survey would last. We also rounded at staff meetings, talked to educators, and also had it in huddles as well. I attended some of those huddles prior to the research surveys as well, just to get that out there. Hey, this is going to be coming in your email. This isn't something unusual. This is actually something from inside SOMC. It's not something to trip you up. So that came up many times. I was thinking that maybe this was a trick to see if I was giving outside information or phishing or something like that. So, but tried to round to make for sure people knew it wasn't. And then here's an example of the invitation inside the paper, inside the weekly beat. This one specifically is the September one in 2019. Idea of some of the survey questions. These are 4 of the questions. Some of them were multiple choice, while others were just true and false, and then compiled the data on right answers and wrong answers from that. But as I remember, about a 25 question survey. So the way we compiled information, we wanted to be able to show a change in knowledge from the first survey, which we would call the pre, to the second survey, which we call the mid, and then to the last survey, which we call the post. And out of all the nurses who returned the surveys, these are 12 nurses that took every single survey. So they were able to show progression of knowledge base. Some people took 1, some people took 2, but these are the only ones that took all 3. And as an average, over 700 nurses were sent invitations. And in the beginning, I think 166 nurses returned the first one, about 90 on the second one, and 79 on the third one. So decreasing returns. When you look at the progression of knowledge from first to second to third, I think it shows what education does for nurses. So first, the baseline was 70.16. So basically 70% of the questions were answered correctly. Same nurses progression to the second survey or exam is 76.83. And then same nurses to the third would be 80.5. So if you were looking at an ABC grading scale, then started out in a C range to a C plus to a B. So definitely big progression clinically for the survey and how the education impacted those nurses. So definitely it's clinically significant, but we also did an ANOVA test as well. Valerie specifically did this ANOVA test and was looking at statistical significance for the differences, and the statistical significance was not there. So clinically very significant, but statistically not. Again, outcome, we used the ANOVA test and it showed no statistical significance, but it did show clinically that there is an increase in the knowledge base with each survey or each exam, if you want to call it that. Recommendations, several recommendations that I would have is maybe just separate the groups. So do only computer learning for a specific number of people and do only hands-on for another group of people and see which one has the greatest impact, which one has the greatest increase in knowledge. So that's one thing. Another would be we only took information from the nurses who completed all three. Well, we could also use 2 points of data. We could use people who took just the first and second, or took just the second and third, or just the first and third surveys. It would still give us information and give us 2 points of data, and be interesting to see people who took 2 versus people who took 3 and see if there was as much of a change in knowledge on 2 points of data as there is on 3 points of data. Implication, certainly a big implication is that we can improve in our knowledge base, that we can improve in the quality of our vascular access care by educating. I think the biggest resources for vascular access education are the Infusion Nurses Society and the Association for Vascular Access. These are up-to-date resources, and they are the cutting edge in vascular access. So bringing more information from these 2 groups into the hospital and presenting it on a regular basis, I think, is a major key to improving our vascular access care and improving the quality of our vascular access care. We also correlated information. We correlated what we scored on the vascular access surveys, the education that was done, and its impact on CLABSI data. So we started this survey set in fiscal year 19, and previous years there were 5 CLABSIs in fiscal year 17 and 4 CLABSIs in fiscal year 18. And in fiscal year 19, where that education started, our CLABSIs went to 0. And then, of course, it stretched into fiscal year 20. And again, that's not a 0, that's a 3. But that 3 is still a progression downward from the higher scores in fiscal year 17 and 18. So definitely think there's a correlation between the education and our CLABSI scores in fiscal year 19, 20, and 21 so far. And again, just putting in writing what I just said, definitely think there's a correlation there. And, you know, the most important thing in this case is that we take care of the patient. You know, those patients are our brothers, mothers, fathers, sisters, cousins, friends. They're the people who we live around every day. And the most important thing is to take care of them and to give them the highest quality care. So, you know, that's the biggest reason for doing this education and doing this research project. Underneath that is impact on the hospital too. So when you deal with CLABSIs or central line associated bloodstream infections, certainly those are tracked and they affect what's called value-based purchasing. And they can have a major effect on value-based purchasing. So looking back to this time period, that the higher rates, the rates of 5 to even 7 CLABSIs a year impacted the hospital on an average of about $2.1 million. So taking that to a 0 saved the hospital $2.1 million in value-based purchasing. Big impact on the bottom line, big impact on how the hospital operates. And I mean, if you look at it on our end, as employees are on our bonuses as well. So certainly important. And again, the patients being the most important reason. And then just references for what I used as a basis for this research. The people you see there are the people who write the standards for INS, the people who are the leaders of the Association for Vascular Access. So taking their expertise there and trying to kind of boil it down and bring it into that survey. If you have any questions at all, certainly feel free to contact me. Again, this is my passion, so certainly willing to help in any way I can. And I'm sure I speak for Kathy as well. Kathy's willing to help in any way possible when it comes to vascular access. It's her passion as well. Thank you very much.